Hello, I'm Edie Strand. The Once Upon a Time Foundation has asked me to speak with you today about childhood apraxia of speech, or CAS. Today I'll be discussing how we recognize this speech sound disorder and also how we have to approach treatment differently for this motor speech disorder relative to other speech sound disorders. I have a few disclosures to mention. I am on the advisory board for the Apraxia Kids organization, and I also receive royalties from ProEd and team of publishers for books that I've worked on, and I receive royalties from Brooks Publishing for the DEMS, which is a dynamic motor speech evaluation that will be mentioned in this presentation. I am also being paid a stipend for this course from the Once Upon a Time Foundation. Now, this introductory video was made both for speech pathologists as well as for people who are not in the profession but have an interest in speech sound disorders, especially childhood apraxia of speech. Although some terminology may be unfamiliar to you, I hope that if you are a parent or a grandparent or anyone who is interested in knowing more about a child's speech problem, that this information will be helpful. The presentation contains some of the information included in the longer 4.5-hour video on this website, but has much less detail and does not cover all topics related to assessment and treatment. Links to videos that show examples of different levels of CAS severity and examples of other types of speech sound disorders to compare with CAS are given, but not shown here in this shorter presentation. So what is childhood apraxia of speech? Well, first, it's important to note that this term is just a label for a type of speech sound disorder. It is not in itself a medical diagnosis. We'll talk a little bit later about what might cause CAS. The label is used when children exhibit a number of characteristics that are associated with the use of that label. Those characteristics include inaccurate movement that results in vowel and consonant distortions, among other characteristics that we'll talk about shortly. The kinds of errors that children with childhood apraxia of speech make indicate that the neural processing for the precision and accuracy of movement is not efficient. Therefore, CAS has been attributed to difficulty with aspects of the motor planning and motor programming processes involved in speech. So, what is actually involved in the act of speaking? Well, this is going to help us understand what we mean by motor planning and programming. So when a person gets ready to talk, first they have to achieve enough respiratory support to put the vocal folds into vibration. So you build up respiratory support and create a sound source or voicing, which then resonates in the vocal tract. There is then constriction of that airstream to make the noise that we hear when we talk. So you constrict the airstream, ba ba shi da da. The trouble with that output is that it didn't mean anything. And this is where planning and programming fits into this, so that this constriction happens in a way that meaningful sounds result. So motor planning and programming might be thought of as setting general spatial, temporal, and acoustic goals. The planning part of that is sort of setting these basic goals. Programming involves specifying the actual parameters of movement for all the structures involved in speech. So what do I mean by parameters? Well, we're talking about the range of motion. For example, how far does the jaw have to open? The direction of movement. Is the jaw going to open or close? The speed of that movement, the force of that movement, and how much muscle tension is involved during that movement. For example, when we go s, we don't have to really contract too many tongue muscles, but if we're going t, we have to use more muscle tension. So as a speaker gets ready to talk, particular muscle groups are selected to begin to contract at a very specific time so that the structures begin to move at just the right time, in the right direction, with a certain speed and with a certain amount of force. and using a certain amount of muscle tension. This allows the articulators to reach a particular temporal spatial target, that is, just reaching the right place in the correct manner at just the right time for the intended syllable or string of syllables. Now, the term praxis refers to this ability to plan and program accurate movement. So let's look a little more closely to praxis deficits versus what we call execution deficits. So when children have trouble with conceptualizing, planning, and programming skilled movement, that is called a praxis problem or apraxia of speech. Likely, it is caused by either some determined, which we call an acquired disorder, or perhaps some undetermined, which we don't often know, problem in cortex or the brain. Execution deficits, on the other hand, are often caused by some impairment in the central or peripheral nervous system and often presents as weakness with decreased range of motion, speed, and force of movement. The speech disorder the label for the speech disorder we use for execution deficits is Dysarthria, and I'll talk a little bit more about that in a moment. Now, in children who have significant problems with praxis for speech, the current thought is that the primary difficulty is with the specification of the movement parameters required to make the articulatory gesture for the correct continuous spatial temporal targets. Now, let me tell you what I mean by that. When I say articulatory gesture, we're talking about the fact that this is a movement that keeps going. For if I'm going to say boy, there's no stopping of that movement. Boy. And that's called a gesture. So it's a continuous movement toward a spatial temporal target. It's important then to think in terms of both assessing and treating movement gestures or movement transitions rather than phonemes or sounds when we're interpreting assessment data and when we're coming to a differential diagnosis. Now, a child might have difficulty with praxis for speech production, and in that case, as I've said before, we use the term childhood apraxia of speech. Or they might have trouble with praxis for non-speech volitional movement. For example, giving a kiss, coughing, doing a lip smack. And when they have trouble with these kinds of activities, we use the term oral, meaning the mouth, but nonverbal, meaning not speech, nonverbal oral apraxia. If a child has nonverbal oral motor problems because of actual weakness or paralysis, they will also have problems in speech production, for which we use the term dysarthria. So I've just repeated and said in a different way the difference between childhood apraxia and dysarthria. Let's look at it now in this diagram where you have praxis versus execution. Under praxis, which I'm reminding you is planning and programming of movement, in the nonverbal context, the label we use is nonverbal oral apraxia. In the verbal context, we use the label childhood apraxia of speech, or CAS. On the execution level, we have more difficulty with actual weakness of the muscles themselves, which results in reduced range of motion, strength, and speed of movement. Now, in the nonverbal context, we might have drooling or even trouble with eating, which we call dysphagia. In the verbal context, we use the label dysarthria. Now, childhood apraxia of speech is often accompanied by what we call phonologic impairment, or difficulty learning the sounds of one language, but not due to problems in planning or specifying the movement. But think about if a child has a lot of difficulty planning movement, that will impair their ability to learn the rule-governed system of phonology. And that's why phonologic impairment is often noted along with childhood apraxia. Children with CAS often have language delay, especially expressive language problems, because of their motor difficulties. They may have a variety of other problems as well, but that depends on other problems that they may have at the same time, whether that might be some cognitive deficits or delay, autism, or other neurobehavioral difficulties. It's most common, however, that we don't know the cause of childhood apraxia of speech when a child exhibits this problem. Sometimes CAS, though, does occur in the context of developmental delay and cognitive impairment, certain kinds of developmental syndromes or conditions such as velocardiofacial syndrome, galactosemia, Down syndrome, sometimes autism. Velocardiofacial syndrome and galactosemia, for example, have shown higher instances of CAS than in the general population. CAS, however, can also be acquired. Young children sometimes have stroke in utero, perinatally, or as very young children. Sometimes children have brain injury or disease or tumors, and any of these things can also result in apraxia of speech. How we assess and treat apraxia of speech in the acquired condition depends on how much speech and language the child had already attained before suffering the injury. Now, let's take a look at childhood apraxia of speech in the context of the range of pediatric speech-language disorders, to put it in some perspective. This basic kind of chart shows that we can look at language and speech in the context of language disorders, speech disorders, or perhaps just voice disorders. In the instance of language disorders, the child may not have any speech problems, but have a language delay or specific language impairment. Many children have a linguistic problem which just affects their articulation. We call that phonologic impairment, where they have trouble learning the rule-governed sound system for their language. In this case, they'll make many substitution errors or sound omissions, but their movement patterns during those substitutions will be normal. Phonologic impairment is often called articulation problems. But so can apraxia of speech be called an articulation problem. So when we look at the speech column, we have articulation problems, we have childhood apraxia of speech, and we have childhood dysarthria. Stuttering also is a speech sound disorder or a speech disorder that can result in some children. That's also considered a speech disorder, but we won't be discussing that today. We also won't be discussing voice disorders today, but I've listed a number of them that can happen to children and can affect their speech output. Now, if we look at a very basic model of speech production, that we see that in order to talk, children first have to have the intent to communicate. They have to have an idea and then the intent to communicate that idea to someone else. And this is at the level of cognition. That's a cognitive process. If they're going to talk or use sign language or write, we say they are symbolizing in some way that communicative intent. For talk, that means they have to do a retrieval process to get just the right word in their mind, then do the phonologic mapping, that is, what phonemes or sounds are associated with that word. And if they're going to use a sentence, they have to put the words in the right order, which we call syntactic framing. All of these processes are considered linguistic. Because, as I said earlier, movement has to occur in a very particular way for speech to be meaningful, we have the next process, which is motor planning and motor programming. Here is where the child has to specify the range of motion, the strength, the speed, the direction of motion, and the degree of muscle contraction. So here we're talking about a motor level of processing for speech. And the last level, the execution level, where the acoustic output actually results, involves those processes of respiration and phonation, making voice, resonance, where the voiced airstream comes through the vocal tract, and then constriction of that airstream, which is the articulation, which is the last level of motor skill to happen. Now let's put each of those things into the model let's put in what the communicative disorder might be if they have a problem at any one of these levels. So first, this cognitive process of ideation or having the intent to communicate. There are some children that have no intent to communicate or no joint attention. We might call that a pragmatic language deficit. It's at the more cognitive level. And an example of that might be someone on the autism spectrum who doesn't yet even have the intent to communicate. So that doesn't involve yet a speech problem. The next level, the linguistic level, involving word retrieval, syntax, grammar, phonologic mapping. The disorders that might occur there would either be language delay or impairment and or a phonologic delay or impairment, not knowing how to produce all the sounds of their language. At the next level of specifying movement parameters, which we called motor planning and programming, the resulting communicative disorder, as we said, is apraxia of speech. And at the execution level, where the muscles themselves are not able to generate enough strength for the movement, we call that dysarthria. Keep in mind, this is a very simplified explanation of this, but for this introductory video, and for those of you that may not have a background in speech pathology, we wanted to make some of this a little clearer to you. Now, unless children with CAS have a coexisting dysarthria, they will not have difficulty moving their muscles with the correct range, speed, and force for non-speech activity such as chewing and swallowing. Similarly, respiration, phonation, that is making voice, will be unimpaired because the primary problem is specifying movement, planning or programming movement to reach the right place at the right time. Now, a lot of children with CAS will also have linguistic problems, but the term apraxia relates specifically to their movement difficulties. So let me give just a little better definition of dysarthria. This is a collective term, really, because it's related to a group of related motor speech disorders that result from disturbed muscular control of the speech mechanism. And dysarthria is manifest as disrupted or distorted oral communication, typically due to paralysis, weakness that comes from abnormal tone, and sometimes due to incoordination, perhaps, of the muscles used in speech. So why is it important to identify childhood apraxia of speech? Well, the most important reason is that that's the way that we choose an appropriate treatment to be implemented for that child. A treatment method should always address the nature of the impairment. Now, childhood apraxia of speech is a motor-based speech sound disorder. Therefore, in order for therapy to be most effective, a treatment focused on improving movement accuracy should be used. And a number of principles of motor learning should be used to guide your treatment decisions as one implements the treatment method. For example, the frequency of treatment, the number, the length, and the phonetic complexity of the stimuli or targets that we use for practice, the types of modeling and cues that we use, as well as how therapy is organized within the session. Finally, the type and frequency of feedback that we give makes a difference in terms of our treatment efficacy. We'll be talking a little bit about these principles of motor learning later in this presentation. So how might we recognize childhood apraxia of speech? Well, basically, in all assessment, it's important that we make observations of the behavioral, both speech and non-speech, characteristics that might be associated with any particular speech disorder label. Then we compare these characteristics with those commonly being associated with the label CAS. However, it's important to remember that we need to make these observations across contexts, that is, different tasks or situations, and we also need to take severity into account because that can make a difference. And I'll be talking more about these characteristics and how we observe them. One way that we observe these characteristics is through testing. So we can use typical language, phonologic, and cognitive assessments that are validated and standardized, or we can make informal observations of language, phonology, and cognition. I'll be talking about the importance of using a motor speech exam, especially a dynamic motor speech exam in the case of childhood apraxia of speech, to make further observations. Informal observations are often made during free play, structured play, watching the child interact with parents or siblings, etc. So here's an example of an apraxia of speech protocol that we might use with children. We start perhaps with a language sample because we always want to build rapport, help the child feel comfortable in the session, and we do that first through free play. And we make observations regarding both phonemic and phonetic inventories and any apraxia of speech characteristics that we might notice. I often like then to do some structured play where I bring out a box with toys that have certain movement structures, articulatory combinations that I want to for which I want to make observations. And that's called structured play, where I am presenting the child with toys that will help elicit things I want to hear them try to say. Now, if the child's older and can name pictures, we might do a test of articulation or phonology to examine where they are in phonologic development. We'll always do a structural functional examination, either very formal or through our observations, to determine or rule out any weakness that would lead us to predict a dysarthria. At that point, we can also test for nonverbal oral apraxia. And finally, in green there, because this is probably the most important thing one can do when looking for characteristics of childhood apraxia of speech, is a motor speech examination. And this allows us to make further judgments regarding the presence and also the severity of characteristics of CAS. So what does a motor speech exam really do? Well, it allows the clinician to observe speech production across utterances that vary systematically in length and complexity. And as the child attempts to imitate these utterances that get progressively harder, we are allowed the opportunity to make observations of those behaviors frequently associated with deficits in speech praxis or childhood apraxia of speech, including sound distortions, timing errors, stress errors, inconsistency, etc., across this hierarchically organized stimuli. But I also want to make the argument for using dynamic assessment in one's motor speech exam. Now, dynamic assessment involves a process in which cueing is provided to facilitate performance, and that helps us see skills that might still be emerging. And it contrasts with static assessment, which is more typical of standardized tests, where the child's skills are measured after a single response with no assistance from the examiner. So I might say it, they respond right or wrong, versus where we really help the child and see what they can do. So there are several advantages of using dynamic assessment. The first advantage is that it allows observations of what the child does when he or she attempts movement gestures for words or specific syllable shapes versus what he does habitually in spontaneous speech. Now remember, without cueing, the child may not increase their attention or effort toward saying a particular word, but even with minimal cueing like watch me or a gestural cue, letting them know it's okay if they do it wrong. If they do, we'll help them. It's common in our experience for the child to more actively at least try to attempt the correct movement gesture. And when we do this, the child is more likely to exhibit some of these characteristics that we associate with the label CAS. The second big advantage in the case of differentiating children with CAS is that we have the opportunity to evaluate all the characteristics associated with the label, but also the degree to the frequency with which they exhibit them and how much time it takes for them to improve with our cueing. Some of the things that we may see are groping that's not evident in spontaneous speech but does occur when the child is trying to imitate specific words or phrases. Inconsistency across trials as cueing occurs. Segmentation of syllables, which occurs only when the child's attempting correct articulatory movement gestures or when the child's attempting to produce a bisyllabic or multisyllabic word. The third big advantage in using dynamic assessment is that it has the potential to facilitate judgments of severity and therefore prognosis. If a child consistently needs considerable cueing to correct or correctly produce a target, or never produces it at all despite all our cueing, then we see his problem as being more severe. On the other hand, if the child improves accuracy of movement with only a few cues, we know that he or she will make quick progress, and it indicates less severity and makes the prognosis better. When using a static assessment strategy, we can't as easily make judgments of severity or prognosis. And the fourth advantage is that treatment planning is facilitated. The types of cues that proved helpful during administration of the test would suggest cueing strategies that are likely to be useful in ongoing treatment. But also, when we review the errors that they make, for example, specific vowel distortions that they may make, the syllable shapes they have more trouble with, helps us facilitate choices in terms of the early stimulus sets, that is, the targets that we practice. Those targets, of course, are just a vehicle that we use for practice to improve the efficiency of the neural processing. But the choice of that stimuli is important, and looking at their results on motor speech testing can help us with that. So we've been talking about how we might recognize CAS. So we said that we make observations of characteristics that are associated with the label over a number of tasks, for example, free play, phonological or articulation testing, as well as a dynamic motor speech exam. So we know now how to make these observations, but what are the characteristics that we associate with the label CAS? Well, first, there are a number of characteristics that children with CAS often present with, but are not necessarily discriminative. That is, it doesn't really tell you that this child has CAS, because other types of speech sound disorders, children will exhibit these same characteristics. These include limited consonant and vowel repertoire, the use of simple syllable shapes, frequent omission of sounds, numerous errors leading to poor standard scores on articulation tests, and finally, poor intelligibility. Now, children with all types of speech sound disorders may make numerous errors. So, numerous errors isn't really a discriminative characteristic. Now, children with phonologic impairment may make more substitution errors, but it's important to note that when they say tat for cat, they're substituting the T for the K sound, the T for the K sound, but the movement for that T is correct. And that's different than in CAS, where that movement would be somewhat distorted or awkward. And finally, any child with a severe speech sound disorder, no matter why, might show poor intelligibility. So intelligibility alone, that is how well the speaker can understand the child, doesn't really discriminate children with CAS. These characteristics, however, are more likely to be discriminative. That is, the children with CAS frequently exhibit these characteristics, which are seen less often in children with other speech sound disorders. The first one is difficulty moving from one articulatory configuration to another. That is, the movements may be awkward or clumsy as the child attempts the continuous movement across a syllable. Secondly, you might see groping, trial and error behavior. And it's important to note that these are typically seen in elicited utterances, that is, when we ask them to say something, versus what they say spontaneously. And then the presence of vowel distortions. This is very common in childhood apraxia of speech, yet rarely seen in more linguistically based or phonologic disorders. These are not vowel substitution errors, but are distortions of the intended vowel. Prosodic errors are often noted to be a problem in CAS, much more so than other speech sound disorders. And there are a number of different kinds of prosody errors. The most common one in CAS is segmentation. So instead of saying happy, they might go ha-be, using equal stress and segmenting the syllables. Lexical stress errors, where the error is on the wrong syllable of the word, like instead of happy, they might go happy, are often common in CAS. Then there are inconsistent voicing errors, and in this case we might hear them say bat, and you can't really tell, was that bat or pat? You can't distinguish if it's voiced or unvoiced, and this is likely due to a timing problem. The addition of a schwa is very common in childhood apraxia of speech and not seen as frequently with other speech sound disorders. And a schwa is like an and this can happen within a single syllable word, such as instead of bike, they might go bayak. Or within a bisyllabic word, instead of baseball, they might say baseball. Or it can happen at the end of a word. Instead of bed, they might say beda. Now the intrusive schwa is very important to treat because their use actually adds an extra syllable to a word, and this greatly impacts intelligibility or the ability to understand the child. The next characteristic more likely to be discriminative are consonant distortions. Now, as I said before, some children might substitute one sound for another, but the movement is accurate. In childhood apraxia of speech, the movement will be inaccurate either in timing or the direction of movement or where the movement ends up, and that causes a distortion of the sound. Now, we do have some video examples of children with childhood apraxia of speech at different levels of severity, and these can be accessed from the Mayo Clinic YouTube channel, video links. I've put them for you on this slide, which you can use to access these. The examples include different levels of severity of CAS, as well as differences between CAS and other speech disorders. So you'll see an example of phonologic impairment and an example of dysarthria. I've also put the link there for the full video with all segments. Especially if you're a parent or a grandparent or a relative who doesn't have a background in speech pathology. The Once Upon a Time Foundation actually sponsored this video that we made through the Mayo Clinic that talks more in depth about childhood apraxia of speech, specifically for parents, answering a number of questions that parents often asked me over the course of many years at Mayo Clinic. A few more comments about differential diagnosis. Because pediatric motor speech disorders are often not emphasized in clinical training programs, the speech pathologists are sometimes not sure when or even whether to use the label CAS. There is now, however, more consensus about the characteristics that should be associated with that label, and we've just reviewed those. So speech therapists can now indicate how many of these characteristics are present over how many tasks in order to confirm that at least some difficulty with praxis for speech might be evident. Then dynamic motor speech testing would allow one to more confidently determine the presence of some of these characteristics as well as the severity of the praxis problem. I believe it's important not to label a child as suspected CAS for an extended period of time. It's important for a speech pathologist to take action to either rule out or confirm the presence of the characteristics of CAS so appropriate treatment can be implemented. One might tally the characteristics as you note them across tasks, of course, including the motor speech exam. Now, it is true that very young children or children that can't yet imitate any speech may not be able to do enough tasks for you to make these observations. In that case, rather than say suspected CAS, it might be important to say that at this point in time, you cannot determine or rule out childhood apraxia of speech because the child cannot yet attempt any direct imitation. In that case, you may choose to start therapy by building the prerequisites for their ability to do a motor speech exam. Now, you might choose to use a motor speech exam that's been validated to differentiate children with CAS from other speech sound disorders. The dynamic evaluation of motor speech skill is a published dynamic motor speech exam which has been validated to differentiate CAS from other speech sound disorders. The clinician will use the total score as well as other observations that one notes during administration of the exam to show to what degree the child exhibits CAS. Now, one doesn't have to use this published dynamic assessment. One can make up your own that matches the child that you're seeing in terms of severity. It might be a very simple short one, or it might be one that's more detailed. How to do this is discussed in the longer video available on the website. And for those speech pathologists who might be watching this, the Once Upon a Time Foundation offers advanced workshops where we get practice in actually doing this. Now, keep in mind that children with childhood apraxia of speech will likely also have phonologic impairment and expressive language difficulty, and they may also have other challenges in addition to CAS, such as receptive language problems and cognitive impairment and physical impairment, such as hemiparesis or ataxia. The following examples of diagnostic statements illustrates this and how it might be written in a report. So diagnostic statement number 1 relates to a child with severe CAS. So one might say this child's severe delay in speech acquisition is due primarily to deficits in motor planning and programming skill, parentheses, childhood apraxia of speech. The characteristics include numerous inaccurate movement trajectories leading to consonant and particularly vowel distortions, groping for articulatory configurations, inconsistent voicing errors, segmentation at attempts of bisyllabic words, and inconsistency across repeated attempts at the same word. He also exhibits a significant delay in phonologic skill and a severe deficit in expressive language. Receptive language is in the low average range, and there is no evidence of cognitive impairment, social or pragmatic language deficits, or dysarthria. So that's just a succinct way to use the label CAS with the characteristics you noted to support that, as well as what the child is really doing well in. The second example is for a child who exhibits phonologic impairment. This child exhibits a severe phonologic impairment characterized by the processes of fronting, final consonant deletion, and stopping. She exhibits numerous consonant and consistent consonant substitution errors, for example, W for R, T or T for D, D for TH, W for L, etc. There is no evidence for CAS or dysarthria. In particular, she demonstrates no consonant or vowel distortions and has normal phonation, normal speech rate, normal prosody, as well as accurate articulatory movement gestures. Receptive and expressive language scores were in the low average range, and there were no cognitive or pragmatic language deficits. The third one is a little bit different, and it shows a common scenario where a child has more than one problem. This child exhibits a moderate phonologic impairment characterized by fronting and consistent typical substitution errors for later developing sounds. In addition, he exhibits a slightly slower rate, more difficulty with multisyllabic words with occasional segmentation, and very occasional vowel distortions, providing evidence for a mild contribution of difficulty with praxis for speech, parentheses, mild CAS. There's no evidence for dysarthria. There's no evidence for receptive or expressive language delay or cognitive impairment. So what happens if the evaluation results indicate characteristics of CAS. That is, what's next? Well, when one plans a program of treatment, it's important to make sure that the treatment focuses on the nature of the impairment. This is a review of something I've already said, but it's important. Let me give you a couple of examples. In dysarthria, where there's actual weakness, the focus may be on increasing background of physiologic effort and or compensatory techniques, such as separating each word, but don't separate syllables within a word. If the problem is a phonologic disorder, then treatment would focus on the phoneme or the sound. But for CAS, one must plan a program of treatment that focuses on facilitating accurate movement rather than teaching sounds of the language. And this is the most important difference in treating a motor speech disorder from a phonologic impairment, or in treating CAS. So now we'll go into a little more detail about what are all those differences that we think about when we treat CAS versus other types of speech sound disorders. Well, in childhood apraxia of speech, the goal or the focus of treatment is really to improve that child's ability to specify parameters of movement so that the articulators reach the right place at the right time for the targeted utterance. Therefore, the focus or the target of treatment is the movement versus the sound, and that changes everything. It changes the words we use when we talk to the child. Instead of saying, okay, we're going to work on our sounds, we might say, all right, we're going to work on moving better so that it's easier to talk. It'll affect our choice of approach. We won't use a linguistic method of treatment for this motor speech disorder. It'll affect the choice of method. If the child has severe CAS, one might choose a method of treatment that's been shown to be effective for children with severe CAS, versus a more mild CAS where one might choose a different but motor-focused method. Certainly it will affect your choice of techniques, pacing, the types of cueing you use. It'll affect how you organize practice during the session. If you practice one word at a time many times, or if you mix them all up and practice each word once as you go through. It'll affect the types and amount of feedback that you give the child. I want to stop here to talk for a moment and give you an example of what we mean by focusing on movement. I'd like you to watch the movement. So if you've got a by screen here with the slides and the video, watch the video for just a moment so you can watch the movement for these different words. Let's start with hi. If you watch me say hi, hi, there's no stopping between the h and the I. It's one continuous movement. Also note that the jaw has to be just the right height. We don't go hi, we go hi. And the movement has to be with the jaw just in beginning with the jaw just in the right amount of millimeters of opening for that sound to not be distorted, or the vowel following to not be distorted. Another example is to watch me say the words boo versus bee. Watch me do it slowly versus the word. If we think of sounds, say the B, you'll see that the movement for that same sound is totally different depending on the sounds before or after. So the boo starts with very rounded lips versus B, which starts with retracted lips. So if we're focusing on the sound and not paying attention to the movement, it would really be harder for the child with apraxia. And I'll give you another example of that in a moment. The take-home message is don't work on production of the sounds in isolation. But for CAS, you want to work on the movement gesture for the whole syllable, because the sound in isolation is just a construct for this mental representation of a sound, B. But if we just say B, E, there's two wrong movements versus the correct B, which is one correct movement gesture. And that's how we make it harder for kids with CAS, or can make it harder. So the idea is don't work on sounds in isolation, work on the movement gesture for the whole syllable. And we'll talk about this a little more. Now, how does one focus on treatment on movement versus sounds? Well, another example, if the nature of the movement impairment is one of weakness due to spasticity or flaccidity, like you see in Dysarthria, then movement is treated by improving physiologic support. But the movement disorder in apraxia is characterized by achieving articulatory configurations and then transferring into and out of those configurations. Therefore, practice should focus on making those movement transitions in the context of speech. The child must be offered the opportunity to practice that movement a lot. At first, the clinician will provide maximum support, having the child watch their face, perhaps using tactile and gestural models, but fading those cues as quickly as possible over time. Because the goal of treatment is to improve movement accuracy, therefore, it's important to implement principles of motor learning. I've alluded to these briefly, and we're going to talk just a moment about them here. A number of these principles have been mentioned and will be mentioned again in this presentation. For example, the need for lots of practice, how to organize that practice for better motor learning, the types and frequency of feedback. I'll say a few more things now, but I want you to keep in mind that this is very simplistic. So when we talk about organizing practice, one can take, let's say if you have 6 stimuli or 6 targets, you could practice target 1 40 times and then target 2 40 times and then target 3 40 times, etc. Or you could do them one at a time, back and forth randomly throughout the session. If a child has severe CAS, we start with more blocked practice so that we can continue to cue and get the movement more accurate and then fade those cues. If we start with random production, it will take them a really long time to acquire the accurate movement for that target. Now, with adults who are doing simple arm movements, for example, they've shown that random practice results in better motor learning. That is, they retain it longer and maintain it over time. The trouble with children that have CAS, especially more severe CAS, is that if we start with random, they get very, very frustrated before they get any accuracy. And it takes a long, long time. But if we start with blocked practice and then reduce those blocks and move toward random production, we are more likely to get quicker acquisition of the correct movement and still work toward good motor learning. With respect to the types and frequency of feedback, we have to think about the fact that we can either give them knowledge of performance, which is what they're actually doing. It's very specific feedback, such as, oh, you're way open, close your mouth a little bit, make your jaw smaller, or make it tighter, or we can just give them knowledge of results. Their response was either right or wrong. For children with more significant CAS, we start with knowledge of performance, we give them very specific feedback, and then as quickly as we can, we fade that to just right or wrong. For example, we might say, oops, that wasn't quite it. Can you fix it? To get them to take increasing responsibility for self-monitoring and being able to do the motor planning and programming on their own. Now, a more comprehensive discussion of how one uses these principles to make clinical decisions is included in the longer video on the website. And for those of you that might be interested in the advanced workshop, you would actually get some practice in doing this. Let me make just a few general comments on treating the praxis impairment in CAS, as well as facilitating motor learning. General principles of treatment include focusing on movement performance, movement patterns, and sequences of movement. We use intensive, frequent, and systematic practice because we want to work toward not just the acquisition of accurate movement, but the habituation of the movement pattern so that they don't have to use such conscious attention all the time. And these are really important parts of all treatment programs designed to improve motor skill. These approaches also include careful construction of hierarchies of stimuli, the use of decreased rate at first, drawing attention to proprioceptive monitoring, that is, having the child really feel where their jaw, lips, and tongue are, as well as the use of visual, gestural, and tactile cues, which, as I've said, are faded as the child improves accuracy of the movement, so that the child takes increasing responsibility and we provide less and less support. One of the things that's often mentioned in treating CAS is the frequency of practice. And there's some literature and studies that have been done that show that the more frequent we provide therapy, the better. For example, 3 to 5 times a week on an individual basis for 20 to 30 minutes of continual practice is frequently recommended for childhood apraxia of speech. Now, I know that's not always possible in many places, but some of us are doing work to figure out how we can overcome some of those barriers so that those children who really need this can have it. They aren't necessarily, if they get this frequency of treatment, they're not going to need it for a long period of time. And it's really important that we do this. Secondly, we need to really maximize the number of practice trials that we have the child do each session. So we have to use reinforcers that take very little time. For example, instead of games and pictures and things that draw their attention away from your face or that take a lot of time, like a spinner and it falls on the floor and you pick it up and all those sorts of things, you want to use things that you can bring out very quickly. So you shape the movement for a number of practice trials, getting closer and closer, and then you might give them a little Nerf ball to throw into a basket, or something to throw at a target, or perhaps something that gets thrown in a box, and when they get so many of these tokens, they get a prize. You'll think of novel ways to keep their interest without taking time away from the task. You also want to be sure to use reinforcers that keep the child's attention to the clinician's face. So modifying the use of rate is also very helpful. So you produce the movements for the utterance very slowly at first, sometimes even simultaneously or in unison with the therapist, and then gradually increase the rate toward more natural rate with continued practice until they produce the movement accurately at normal rate and with normal prosody. Sometimes I like to have the child stay in the initial articulatory configuration for a second or two before actually starting the movement gesture. For example, if we're going to say boy, I might have them get ready, stay there, so that they have a chance to feel it. The use of slower rate at first in general, as well as staying in that initial configuration, especially if they had trouble getting there, helps maximize proprioception, or their ability to feel what's happening in the oral mechanism. With respect to feedback, I've talked about briefly the knowledge of results versus performance. Now, at first, feedback should be very frequent and focused on performance. So we help the child know what was wrong about the movement rather than just whether it was right or wrong. And we give them advice on how to fix it. For example, make your tongue a little tighter, close your jaw, ooh, not so fast. Then as the child becomes more accurate with the movement, feedback should become more random in order to improve motor learning or generalization. Another important point in treating children with CAS is that children with apraxia need to maintain what we call co-articulation between as well as within syllables. So it's important to avoid pausing and voicing or movement gestures within syllables, so the child has the opportunity to practice the complete movement gesture in the correct co-articulatory context. For example, separating the phonemes in a word for example, boy, such as ba, oi. And then having them try to blend those movement gestures is very difficult for children with apraxia of speech because you're really teaching them two wrong movement gestures. We never go ba when we say boy. The correct target is boy. If you weren't watching, watch again. Boy. That's the target. So while separating the sounds might be an appropriate technique for some children with phonologic impairment, and it's actually something we've done for a long time in speech pathology that can be helpful for some children, it really does increase the difficulty for kids that have planning and programming deficits, or CAS. And we typically say that we should not include that as a strategy in therapy for children with apraxia of speech. Prosody is the next thing to talk about because for these children it's very important for children with apraxia of speech to begin to work on prosody very early. What we can build into some therapy techniques is that as the child becomes more accurate, the therapist gradually increases rate toward normal and then begins to work on varying prosody a little bit. So we'll talk about that in a few minutes. It's important to work on really establishing correct lexical stress and phrasal stress. Lexical stress would be like happy instead of happy, and phrasal stress like I want more or I want more, depending on the context. Variability or varying the prosody is also important early in therapy because it helps us establish some flexibility in their motor planning and programming. And this is discussed in much more detail in the longer 4.5-hour course as well as in the advanced course. So now just a few comments on treatment planning and the implementation of treatment techniques. There are a whole range of treatment strategies for children who exhibit speech-sound disorders, and a number of these interventions are designed specifically for children with motor speech impairment. So there are a number of these that are specific to childhood apraxia of speech. The most recent systematic review, which is actually a method of evaluating research evidence for treatment efficacy. This was published in 2014 by Elizabeth Murray and her colleagues in Australia. And it's an important resource to find out what methods for treating CAS have some evidence for their efficacy. In that important paper, they concluded that 2 motor treatments, DTTC or dynamic temporal and tactile cueing, as well as REST, and 1 linguistic treatment, integrated phonologic awareness intervention, are best suited for working with children who have CAS. They also noted, as they reviewed the literature, that sessions at least twice a week and a dose above 60 trials per session were better than anything less, and that DTTC appeared to work well for younger children as well as older children with more severe CAS, and focuses on producing more accurate movement at the syllable level or longer using very functional words. REST appeared to work well for children 7 to 10 years of age with mild to moderate CAS. They put a lot of emphasis on prosody and naturalness as well as articulatory accuracy. And then integrated phonologic awareness intervention appeared to work better for children 4 to 7 years of age with mild to severe CAS and language impairment. We'll be talking about the 2 motor approaches to treatment that were shown to be effective in just a little bit. So what's involved in treatment in general? Well, in my perspective, the first and most important thing one has to do when beginning therapy is to explain the disorder to parents in a way that they really understand, and I'll give you some example of that. Then there's planning the therapy and all the clinical decisions that go into planning therapy, and then the clinical decisions that you have to make while you're implementing therapy. Am I going to slow down? Am I going to speed up? Am I going to provide more cueing? Am I going to fade the cue, etc.? So educating parent, this is so important, and I think I'm I care a lot about this because of the many questions I get, phone calls and emails from parents who have been told their child has apraxia of speech and it causes them a lot of distress. For example, I evaluated a young boy who had a severe speech sound disorder. He had been given the diagnosis of CAS in his home community. The parents were very anxious about what that meant. They believed it was a medical problem and even asked me if he would need surgery. They were really distraught. It was difficult for them to even listen to my explanation after I was able to confirm the diagnosis. I listened for a long while to their concerns and questions, and then was able to start a discussion about the nature of the problem and, most importantly, what we could do about it. First of all, I assured them that childhood apraxia of speech is just a label for a subset of children with speech sound disorders. I explained the difference between a medical diagnosis and a speech diagnosis. I talked about the nature of CAS and explained that there are specific techniques which work. Finally, and probably most importantly, I was able to tell them that most children with CAS will be verbal communicators. I then went over my initial goals. I explained my rationale for them. I explained my choice of approach, the method and initial stimuli, why I made those decisions, and talked with them about what they can do to help and that I would be guiding them in this along the way. This is such an important aspect of treating the children, that is, helping the parents understand the nature of the disorder, the fact that we do know what to do to help these children, and that we are going to help them be partners with us in that. So what are these clinical decisions that we make during treatment planning? Well, we have to decide on, are we going to take a motor approach or a linguistic approach? If it's CAS, we're going to take a motor approach. What specific method should we use? And a method, again, is just a program of treatment that really involves just techniques and types of cueing. We have to decide the frequency of treatment, the length of sessions. One of the most important decisions you'll make are what are the initial targets or stimuli that you will use for practice? How will practice be organized? What type of feedback am I going to give at first? And how and when am I going to fade that? Now, treatment methods for CAS fall into 4 general categories, and I'm just going to give you an example, one example of each. So an articulatory type of treatment might be this dynamic temporal and tactile cueing, and I'll be explaining more about that in a minute. A tactile gestural method would be one where the cueing methods are primarily gestures or tactile cues, that is touching the child to help them get into particular gestures. An example of that is prompt. And then prosodic, which would be something like melodic intonation therapy, or rest, which is also articulatory, which we'll talk about in a minute. Augmentative communication is also very important. We don't have time in this introductory lecture to talk about this, but it's very important that young children have a way to communicate. So there's lots to think about with the whole topic of augmentative communication. There's a lot of children who are given large, somewhat complicated devices, or even iPads with somewhat complicated methods of choosing words that are then spoken. Our bias is that a child has CAS and we feel the prognosis is good for improvement within, to get them talking within a year or so, that we use lower tech ways of augmentative communication, such as naturalistic gesture and simple sign. Now, in this shortened presentation, I'm going to describe 2 methods shown to have efficacy in the Murray article, DTTC and REST. There is more information on other techniques in the longer 4.5 video. So dynamic temporal and tactile cueing was designed and is most appropriate for severe CAS. It's based on integral stimulation, that is, listen to me, watch me, do what I do. The direct imitation emphasizes both auditory and visual models, and it's extremely facilitative to children with CAS. So this involves having the child watch the clinician's face, and that's a really powerful cueing strategy for children with CAS. There are some prerequisites for the use of DTTC. The child must have joint attention and the intent to communicate, and must have shown you that they initiate attempts at communication, even if it's pointing or gesturing. They have to have cognitive skill that allows them to volitionally try the movement for the utterance. That is, they have to be able to try to imitate. They have to be able to focus attention just for a few minutes at a time. It's pretty easy to build their tolerance to practicing more, but they have to be able to attend for 1 or 2 repetitions at least before you feel they're ready for this kind of treatment. Now, this treatment emphasizes the shaping of movement gestures for speech production in the continued practice of those gestures in the context of speech. The rationale comes from the assumption that the nature of CAS is that they have an inefficiency in the ability to plan and program movement for speech production. And that leads to the conclusion that I've made a few times already, that the focus of treatment can't be on the sound or the phoneme, but must be on the movement gesture or movement transitions that create the acoustic signal for the sound combinations. That's an important difference. So integral to DTTC is this use of a hierarchy of what we call temporal delay. It's just the time delay between the clinician's model and the child's response. For these more severe children, we start by saying the target utterance simultaneously and slowly. We say it at the same time while they're watching our face, our lip movements, lip, jaw, tongue movements. Then once they're accurate in simultaneous production, we move to direct imitation. Then we add a delay. The clinician says it, short delay, child says it, until finally we're doing spontaneous production. This method of fading the cue and allowing the child to take increasing responsibility for producing the accurate movement on their own matches our goal of improving the efficiency of the neural processing. Now, other cues are also used at each level of the hierarchy. Visual cues, have them watch your face, gestural cues, tactile cues. Now, at first, maximum cues are provided. Then they're faded, giving the speaker increasing responsibility to formulate the plan and specify the movement parameters on his or her own. The hierarchy, as I said, starts with simultaneous production, moving to immediate repetition, repetition after delay, and then spontaneous production. Again, the rationale is to at first provide maximum support, make the feeling or the proprioceptive information more salient for the child, allows for more accurate movement, and then fades the amount of support to maximize motor learning. So the clinician models the utterance, child repeats. If it's okay, do it again. If not, you go back to simultaneous. In simultaneous production, you may have to use tactile and gestural cues. You may have to use typical phonetic placement techniques that we've used forever in therapy. And to maximize proprioception, we may hold the articulatory position longer. The therapist then, in the simultaneous production, says the word along with the child. And as I said, you might have to use phonetic placement strategies to get them there. When he gets to that initial target, have them stay there for a few seconds. Now, if the clinician feels the stimulus, the target for practice that's been chosen is appropriate, and the child still can't do it simultaneously, one strategy that has worked quite well is to take out the voice. This reduces the motor planning requirements because it takes out the whole motor planning specification, movement specification for the respiratory and laryngeal muscles. So what you have the child do is just along simultaneously with the clinician, produce the movement. So if you're working on boy, together you would just do until it's accurate, then slowly build in a whisper and then voice. This is very successful for many children rather than throwing out that stimulus and choosing another one. So as I said, you continue to practice the word simultaneously. Lots of feedback at first, gradually move to less feedback. When the child is accurate at normal rate and you varied prosody a little bit, then you go to direct imitation. They might falter. You can go back to simultaneous or add a mime. So you say, okay, watch me. I'll say it, then you say it, but watch me. And you say boy, and while they're trying, you go boy. And that mime is often enough just to get them over that hump. And you do that until they can easily imitate. You continue to proceed, adding and fading cues. Then when they are accurate and at normal rate, you add the delay and have the child repeat after 1 or 2 seconds. I say it, boy. They repeat, boy. Again, you're going to add or fade cues until the child's accurate at normal rate, etc. And then you can begin to elicit the utterance spontaneously. Keep in mind, the hierarchy of cueing is not linear or static. It's constantly changing as the therapist adds and fades cues. Also, you'll have more than one target that you're working on at any one time, and those targets might be in different places in the cueing hierarchy. Now, this has just been a very brief description of this basic hierarchy and cueing strategies. The longer video on the website has more complete descriptions and video examples. And in the advanced course for the speech pathologists who may be watching, we actually give you a lot of practice in using this technique. You can see some video examples of DTTC, again, on the Mayo Clinic YouTube video segments. This one happens to be segment 6, and I've given you the link here, and you can actually see some examples of CAS treatment using the DTTC method. All right, rapid syllable transition, or REST, is another method that's been shown to be effective for CAS. This for a little bit older children or children that don't have real severe CAS. REST incorporates theories of motor control and motor learning and incorporates principles of motor learning. The goal is a little different than the goal in DTTC. The goal here is to maximize long-term maintenance and generalization of treated speech skills. REST involves intensive practice in producing multisyllabic pseudo words or nonsense words such as too bigger, to improve the accuracy of the speech sounds, but also to improve the practice of transitioning rapidly and fluently from one sound or syllable to the next, and a lot of practice in control of the melody or prosody in the form of relative stress placed on each syllable within a word. So they might go too bigger, too bigger, too bigger. REST involves 2 components, a pre-practice component where the stimuli or targets are taught with cues to shape accurate movement production with immediate and specific feedback given, followed by a longer practice component that incorporates principles of motor learning that have been shown to facilitate more generalization, such as using more knowledge of results versus specific feedback and the timing and fading of cues. There's efficacy data both for DTTC and for REST. These are the articles for REST, and at the bottom there I've put a website where you can learn more about REST and see examples of REST being performed. We have, just as an aside, had some good success with using DTTC for children and then moving to bringing in REST therapy also, and then moving just to REST, so that we go from developing accurate movement patterns, getting all the vowels correct, etc. And then when we feel that their praxis problems are ending up being more prosodic and not quite as natural, then REST can be a nice technique to move into from DTTC. Just a few conclusions, conclusionary statements. Treatment for CAS really requires a few things. It requires that the clinician, the speech pathologist, be well aware of the motor processing involved in speech production and the way in which these motor processes interact with language. Further, the clinician should be knowledgeable about the principles of motor learning and how to apply these principles to the treatment decisions that you make. It's integral to treatment planning. Just a couple of treatment pearls that you could use next week if you're a speech pathologist. If you do nothing else but incorporate these changes, you will see some differences in not just the efficacy of your treatment, but the efficiency of your treatment, how rapidly the children show change. First, just increase the number of responses per session. Take away things you're doing in treatment that take the child's attention away from your face. Increase the number of practice trials with your shaping the movement as they do it each session. Increase the number of sessions per week if that's possible. Increase the child's motivation and ability to watch your facial movements, add or fade cues as necessary. A few do's and don'ts. Do maximize responses per session, and you can do that by not using games and pictures that take their attention away from your face and decrease the number of responses per session. And secondly, practice the movement gesture for the syllable as a whole without interruption. That is, don't separate syllables, ba, oi, up, e. Rather, it's boy, up, me. Few important points to take away. CAS is a label for a type of speech sound disorder, not a medical diagnosis. The focus or the target of treatment is the movement versus the sound, and that changes everything. Finally, maximize responses, all the response trials per session. Again, rather than use pictures or games, use quick reinforcers, get them to look at your face. And when you're making your decisions, you want to incorporate the principles of motor learning, such as moving from block to more random practice, from more specific feedback to just right or wrong, etc. And for sure, make sure that you have a rationale for every clinical decision that you make, and be confident in your ability to explain that decision to parents and others. Thank you.